So today we are going to discuss the second part of the antidepressant drugs. All the drugs have mentioned, the newer drugs are coming. So these are the selective serotonin reuptake inhibitors. Selective serotonin reuptake inhibitors or SSRIs. What are the name of the drugs? Fluoxetine, sertraline, paroxetine, fluvoxamine, citalopram, escitalopram. What is the mode or mechanism of action? It is inhibiting the reuptake of the serotonin from the synaptic cleft. So this is the action here. This reuptake is inhibited by these drugs, and there is an increased amount of serotonin in the synaptic cleft having action on the postsynaptic receptors, leading to the elevation of the depression or psychosis. So selective serotonin reuptake inhibitors, the mechanisms are: selectively it inhibits the serotonin reuptake, increase the synaptic availability of the serotonin, negative feedback system restores the homeostasis, repeated treatment leads to down regulation or desensitization of the autoreceptors, increased production and the release of serotonin, indirect enhancement of the norepinephrine release through 5-hydroxytryptamine 2A heteroreceptors. So selective serotonin reuptake inhibitors, the mechanisms are: selectively it inhibits the serotonin uptake, increase the synaptic availability of the serotonin, negative feedback system restores the homeostasis, repeated treatment lead to the down regulation and desensitization of autoreceptors, increased production and the release of serotonin, and indirect enhancement of norepinephrine release through 5-hydroxytryptamine 2A heteroreceptors. So you can see this is the diagrammatic presentation of the mechanism of action. Here we are saying these are the 5-hydroxytryptamine or serotonin. These are the reuptake transporter which is getting inhibited by SSRI, leading to the more availability of these serotonins within the synaptic cleft, which have its action on the 5-hydroxytryptamine receptors. What are the uses of these drugs? Number one is the endogenous depression. So SSRIs are the first choice of drugs for the endogenous depression, especially in the severely depressed patient, and tricyclic antidepressants is coming later on. MAO inhibitors are the late choice. So endogenous depression, SSRIs is the first choice of drugs, tricyclic antidepressants in the severely depressed patients, and MAO inhibitors are the late choice. Duration of the treatment is 6 to 9 months. Depressive phase of the bipolar disorder. It also can be given in the panic disorder, generalized anxiety disorder, obsessive compulsive disorder, and the chronic pain like the tricyclic antidepressant is given venlafaxine. It also can be used in the attention deficit hyperactive disorder, where atomoxetine is preferable drug. Interactions, it has got the interaction with the tricyclic antidepressants as well as with the serotonin syndrome. So here we can see these are the action, these are the dendrons, these are the actions. So here this is the normal function. What is happening? These are the autoreceptors where the serotonin is getting being taken up and getting attached to these autoreceptors, leading to more secretion. So this is the depressed state. There is a low 5-hydroxytryptamine, up-regulated receptors are there, low amount of signals in the neuron to release the more hydroxytryptamine. So less amount of signal is coming. These are the signals, less amount. These are the sensitivity or the up-regulated receptors. 5-hydroxytryptamine within synaptic cleft is very low, and all these are leading to the depressed state of the mind. Now, antidepressant action. What is it is doing? It is blocking the 5-HT reuptake both in the dendrons as well as in the actions, leading to more availability of the 5-hydroxytryptamine outside the nerve cells and especially in the synaptic cleft. Now, what are the causes for the therapeutic action and the side effects? So, we can see this is the serotonin pathways. Here, it is acting on the limbic system as well as in the basal ganglia and also in the cortex through the raphe nucleus. So, what is happening? When it is having its action, the serotonin having its action on the frontal cortex, there is an elevation of the mood. When it is having its action in the basal ganglion, what is happening? There is the disorder in the movement which is known as the akathisia or agitation, and also the obsessive compulsive disorder. So a person is repeatedly doing the same job, that is the OCD. When it is having its action in the limbic system, there is a development of anxiety. When it is having its action in the sleep centers, so there is insomnia, patient can't sleep. And on the spinal cord, it has a sexual dysfunction. When it has its action on the brainstem vomiting center, there is always a tendency of nausea and the vomiting. Having its action on the gut, there will be the development of the gastrointestinal cramps and diarrhea. So these are the side effects of the SSRIs. So in a nutshell, what are the disadvantages of the SSRIs? Number one is the serotonin syndrome, which is very important, and it is symptoms develop like fever, rigidity, myoclonus, agitation, restlessness, sweating, twitching, and convulsions. Tolerance to the antidepressant effects of the SSRIs also develop. When there is an acute withdrawal of the SSRIs, there will be the development of the paresthesia, body ache, bowel upset, agitation, and the sleep disturbances. So on the adverse effects, as we have seen on the GI tract, what will happen? Cramps will be there. There will be the sexual dysfunction, agitation and restlessness. We have seen it occurs when it has its action on the cortex. It has to be treated with the help of the fluoxetine. Insomnia, when it is having its action on the sleep centers. Venlafaxine is a potent inhibitor of the serotonin transport and the weaker inhibition of the noradrenaline reuptake. It is an important drug, you have to remember about it. And bupropion is another drug which is the inhibitor of both the dopamine and the noradrenaline uptake. So the drug will come on later on. So examples is the first fluoxetine. It is a longer acting drug, half-life is the 2 days, and active metabolite persists inside the body for 7 to 10 days. So it is the serotonin reuptake inhibitors. Also it has some action like the norepinephrine reuptake inhibitors and having its action agonistic on the 5-hydroxytryptamine 2C receptors. Fluvoxamine, another drug which has the action like the serotonin reuptake inhibitors, also have its action on the adrenaline receptors also. Plasma half-life is 18 hours, it doesn't have any active metabolite. Sertraline, again its half-life is 28 hours and active metabolite is longer acting. Paroxetine, it is not used in the pregnancy, so it is contraindicated, and the half-life is the 20 hours. It has both action as the serotonin reuptake inhibitors as well as the norepinephrine reuptake inhibitors. Citalopram, it is half-life is 33 hours, that is the longest half-life, and it is the serotonin reuptake inhibitors. Then for which group of patient we will recommend to the SSRIs? or number 1, serotonin deficiency syndrome. What will happen is the depressed patients with anxiety, pain and the phobias, post-traumatic stress disorder, obsession, compulsions or eating disorders. Other uses of SSRIs are first line of drug is OCD. First line of drug for the obsessive compulsive disorder or OCD, it can be given in the panic disorders, in the social phobias, eating disorders, post-traumatic stress disorder, in anxiety, in the premenstrual syndrome, the body dysmorphic disorder and the kleptomania. Now we are coming to the next group of drugs, which are the selective noradrenergic reuptake inhibitors. Examples the reboxetine, atomoxetine and the viloxazine. What are the indications? Number 1, when there is a depression with the noradrenergic deficiency syndrome. So there will be the development of the fatigue, apathy, psychomotor retardation and attention deficit and impaired concentration. Deficiencies in the working memory is also depressed. So we have to convert these apathetic responders of the SSRIs in the full remitters. So with the help of the selective noradrenergic reuptake inhibitors, we can convert these apathetic receptors of SSRIs in the full remitters. And these NRIs, as a selective noradrenergic reuptake inhibitors, are also useful in severe depression. It is also an adjunct to serotonergic antidepressant when the dual transmitter mechanisms are necessary. So when it is a dual transmitter mechanism is necessary, it is having its action along with the serotonin. Again, we are coming to the therapeutic action and the side effects. This is the norepinephrine pathway. So it is a frontal cortex, and it is in a locus coeruleus, then it is in the limbic system, all this basal ganglia, all this is the pathway for the drug. Now, what is happening when it is having its action on the frontal part? Beta 1 receptors are there, so there will be the development of the depression. When it is having its action on the alpha 2 receptors, it has the attention. When it is acting on the limbic system, energy level will be decreased and the patient will develop the agitation and emotions. When it is having its action on the cerebellum, there will be the development of the tremor. On the brainstem, it causes the decrease in the blood pressure or fluctuation of the blood pressure. On the heart of the pupil, what will happen? That is the tachycardia. On the bladder, it will develop the urinary retention. So, pseudocholinergic syndrome develop, leading to the increased sympathetic activity. So norepinephrine and dopamine reuptake blockers, so bupropion, this is the newer group of drugs, so newer antidepressant, which is having its action both on the norepinephrine and the dopamine reuptake blockers. What is happening? The hydroxylated metabolite of the bupropion is a powerful inhibitor of the norepinephrine and dopamine reuptake. Patients who cannot tolerate the serotonergic side effects of SSRIs, those can be given or recommended for the bupropion. Bupropion sustained release is also useful in decreasing the craving associated with the smoking cessation. And there is last point is there is an increased seizure risk. So these are the newer antidepressant. Number 1, having its action, the dual action on the serotonin as well as the norepinephrine reuptake inhibitors. Very important drug is the venlafaxine. And this is selective only these two actions. This is the serotonin reuptake inhibitors and also norepinephrine reuptake inhibitor. Examples as the milnacidine, duloxetine, this venlafaxine. So if we go through this, what we will see, multiple mechanisms of the drugs are there, side effects will develop, the patient will be depressed, especially with the help of the tricyclic antidepressant. When it is converted to the SSRI, that is the serotonin reuptake inhibitors, then the single selective mechanisms are there and ultimately leading to our well-being. Third group is there is a multiple therapeutic mechanisms are there, especially with the SNRI, that are serotonin norepinephrine reuptake inhibitors, or the blockers of the blockers of these autoreceptors like alpha 1 and alpha 2, where there is a development of well-being. So more recently the trend has been developed to add the multiple mechanisms together to improve the tolerability and enhance the efficacy, especially in the resistant cases. Why multiple mechanisms are important for the antidepressant drugs? Because especially the newer antidepressant that doesn't act in a single pathway. Some of the drugs is blocking the alpha 1 receptors, alpha 2 receptors, some are blocking the autoreceptors, and some has the action like the tricyclic antidepressants. So there is a different mechanism of action. Therefore, to increase the remission rate in the major depressive disorders, it is very good compared to the specific serotonin reuptake inhibitors. For example, the venlafaxine seems to have the greater efficacy as the dose increases. Venlafaxine is preferred in those who are treatment resistant to the SSRIs and the other antidepressant, and those who are responsible but not remitters of SSRI or other antidepressant. Other drugs is the TCAs and MAO inhibitors. So dual serotonin norepinephrine actions is via the alpha 2 antagonism. Here is the autoreceptors, we read the presynaptic receptors. So due to the blocking, there will be the more availability of the serotonin and the norepinephrine. These are the main receptors, is the 5-hydroxytryptamine receptors. Now again we can see this is the alpha 2 antagonist which is blocking on the presynaptic membrane these alpha 1 receptors. Even in the postsynaptic, alpha 2 autoreceptors is also blocking presynaptic 1, leading to what? There is a 5-hydroxytryptamine accumulation will be there. So ultimately there will be the increase in these drugs or this transmitter, and there will be the well-being of the patient. So all the NNSA, that means which is having its action on the autoreceptors, they have action on the 5-hydroxytryptamine 2A, 3 and 2C receptors also. Now we are coming the serotonin 2A antagonist reuptake inhibitors. Trazodone and nefazodone. These are two atypical antidepressants which blocks the reuptake of serotonin. Selective serotonin uptake enhancer, tianeptine and amineptine. It is these inhibitors is aglomelatin. Norepinephrine, dopamine, these inhibitors is the aglomelatin. And selective serotonin uptake enhancer is the tiazeptine and the amineptine. So new antidepressants which are in the development now are the beta 3 agonist, 5-hydroxytryptamine 1A antagonist, dual 5-hydroxytryptamine and dopamine reuptake inhibitors like the minoprine, 5-hydroxytryptamine 1D antagonist and neurokinin antagonist. Another drugs which is coming from nature is the herb, that is the St. John's wort. Active ingredients is the hyperforin, hypericum, and it is well tolerated. It is a potent MAO inhibitors. The augmenting agents, the agents which elevate the mood, those are the lithium, especially in the bipolar disorder, thyroid hormones, buspirion, pregnenolone, and also the estrogens also. So here the chart. So how the antidepressant should be given? If it is monotherapy is given, it can be given along with the SSRIs, that is the serotonin reuptake inhibitors like the fluoxetine. Otherwise, we can give the bupropion, atypical drug, venlafaxine, mirtazapine, nefazodine, all these are very atypical drugs. Now we are coming to the first line augmentation. First line augmentation is done with the help of the lithium and the buspirone. Next, the second line augmentation with the help of the dopamine, the epinephrine, benzodiazepine and the trazodone or hypnotics. Second line monotherapy with the help of the tricyclic antidepressant or MAO inhibitors. Antidepressant combination is very good and it should be given, and because the two drugs will have the different mechanism of action. So management of depression is by electroconvulsive therapy, that is a major depression to get rapid effect, pharmacotherapy with antidepressant and the psychotherapy. So now the portion of the antidepressant has finished. You have to go through the book as well as through the slides. Anything, query, you can come back to me and I will try to answer. So thank you all.